So this is the most frequent tumor constellation in all testicular cancer patients in general, seminoma stage 1. It occurs with a rising trend in more than 45% of germ cell cancer presentations. Without additional therapy, after orchiectomy, 80 to 85% of patients remain relapse-free, and the cure rate of all seminoma stage 1 patients in the long term is nearly 100%. The main management options for seminoma stage 1 patients are surveillance. That means observation without any adjuvant therapy, as well as adjuvant chemotherapy, which offers the opportunity to reduce the relapse risk. Adjuvant radiotherapy has been largely abandoned in the last 5 to 10 years and is reserved to very rare clinical situations. For many decades, radiotherapy has been the preferred adjuvant therapy option in seminoma stage 1 patients. So the question whether single-dose carboplatin monotherapy with AUC7 is as effective as radiotherapy was addressed by a recent published trial carried out by Tim Oliver. Random assignment was between radiotherapy and one infusion of carboplatin dosed at AUC7. The primary outcome measure of the study was relapse-free rate after adjuvant therapy. Overall, 1,447 patients were randomly assigned. Relapse-free rates at 5 years were 94.7% for carboplatin and 96% for radiotherapy, a difference that was not statistically significant. One death as a result of seminoma occurred in the radiotherapy arm. So the study showed the non-inferiority of carboplatin versus radiotherapy. Carboplatin was not able to rule out the development of a contralateral germ cell tumor as assumed by some investigators before. So what is the problem about radiotherapy? Why has it been abandoned from the standard treatment recommendations? Levenstein et al. Published a SEER database analysis on the risk of second cancers among long-term survivors of testicular clinical stage 1 patients treated with infradiaphragmatic radiotherapy with a dose of about 20 to 26 Gray. A cohort of 4,757 survivors treated with radiotherapy was followed for more than 10 years. And second cancer incidence was compared to that of the general population. During the follow-up period, 19%, a very high percentage of the patients developed second cancers. The excess of second cancers in long-term survivors was statistically significant. The observed to expected ratio was 1.51 with a 95% confidence interval of 1.38 to 1.64. Sites with statistically significant excess risk were the thyroid, pancreatic, bladder, non-bladder urothelial, that means tumors of the upper urinary tract, as well as the hematologic system. So the conclusions of this and other studies with similar results were that infradiaphragmatic radiotherapy is associated with a significant and relevant risk of second cancers, and that policies for treatment stage 1 seminoma should be revised. As a consequence, adjuvant radiotherapy is no longer recommended for the treatment of clinical stage 1 seminoma, especially in younger patients. So, do we have prognostic factors for relapse in stage 1 seminoma able to guide the decision if adjuvant therapy should be administered or not? The best evidence for stratifying the risk of recurrence in stage 1 seminoma resulted from a pooled multi-institutional analysis that identified the presence of retic-testis invasion and large tumor size greater than 4 centimeters as the most important factors for the risk of recurrence. It was postulated that the presence of both factors portends the highest risk of recurrence, approximately 30%, and enables better patient selection for the adjuvant treatment. Unfortunately, this data could not be validated in a recent trial presented by Chung et al. At the ASCO 2010. This international validation study revealed that the only parameter with prognostic significance was tumor size as a continuous variable. However, in the current dataset, neither retic-testis invasion nor tumor size reached statistical significance in multivariate analysis. Nevertheless, the absence of both risk factors, retic-testis invasion and tumor size greater than 4 centimeters, is associated with a low relapse risk of 6%, as confirmed by a large retrospective study of the Spanish Germ cell cancer collaborative group published by Aparicio et al. In 2005. Therefore, the recent EAU guidelines recommend a surveillance strategy without any adjuvant treatment in this group of patients harboring none of the both risk factors. So, do we need a surveillance strategy for all patients? One might struggle with the potential risks of surveillance strategy. In fact, surveillance is a very safe therapy, as shown by a large Danish cohort study that revealed an excellent 10-year cancer-specific survival of more than 99%. Of course, a good patient compliance is a prerequisite for a successful disease management. To summarize, surveillance is the primary recommendation for patients with clinical stage 1 seminoma, harboring a 5-year relapse rate of 12 to 20%. Carboplatin-based chemotherapy, that means one course at AUC7, can be recommended as an alternative to surveillance patients with stage 1 seminoma that carry one of the two before mentioned risk factors or that are not willing to tolerate the higher risk of relapse with a surveillance strategy. Radiotherapy is no more recommended due to the induction of second malignancies by radiation therapy, as shown before. So we now go on to localized non-seminoma, that means clinical stage 1 non-seminoma. It represents more than 35% of germ cell cancer patients and is thereby the second most manifestation of testicular cancer. Up to 30% of non-seminoma patients with clinical stage 1 have subclinical metastasis and develop relapse if surveillance as the only follow-up after orchidectomy is administered. Up to 30% of non-seminoma patients with clinical stage 1 disease have subclinical metastasis and will relapse if surveillance is the sole follow-up modality after orchidectomy. Risk-adapted treatment is currently based on the risk factor of lymphatic or vascular invasion. Patients with positive vascular invasion in the histopathology workup will have a relapse rate of about 47%. that means relapse-free survival of 53%. Those without vascular or lymphatic invasion have a relapse risk of only 13%. The cure rates in non-seminoma stage 1 patients is in general also close to 100%. Management options for these patients are, as in seminoma, surveillance, as well as adjuvant chemotherapy. In contrast to seminoma, the BEP scheme is used, consisting of bleomycin, etoposide, and cisplatin. From 1995 to 2005, 874 Norwegian and Swedish clinical stage 1 non-seminoma patients were included in the prospective community-based multi-center Swinoteca study. Patients were restaged 6 weeks after orchidectomy based on vascular invasion in the primary tumor and the patient's preference, close surveillance, or treatment with brief adjuvant chemotherapy with BEP was chosen. Relapse rates according to risk group and adjuvant CT were as follows. Without adjuvant treatment in the high-risk group, the patients had a 3-year relapse rate of approximately 50%. That could be reduced to 3.5% by only 1 cycle of BEP. A second cycle of BEP reduced this risk to 0.2%. Low-risk patients, that means patients without lymphatic or vascular invasion, had a relapse risk on surveillance of 12.6% only. If 1 cycle of BEP was administered, the relapse risk was reduced to 1.4%. So the absolute risk reduction is in comparison to the high-risk patients much lower, roughly 10% compared to about 40% in vascular positive patients. Therefore, in the group of vascular negative patients, the benefits of 1 course of BEP does not balance with the therapy associated side effects, and surveillance seems to be the best option for low risk, that means vascular negative clinical stage 1 non-seminoma patients. So, should we give 1 or 2 cycles of BEP? 1 course of adjuvant BEP reduces the risk of relapse by about 90% in both vascular positive and vascular negative non-seminoma patients. A second course of BEP will virtually eliminate relapses in vascular positive patients, however, thereby increasing the total burden of chemotherapy for these young patients. This second course is overtreatment in about 96.5% of patients. Over time, this has, after extensive debates, been implemented into the current therapy guidelines, where only 1 cycle of BEP is now recommended in vascular positive clinical stage 1 non-seminoma. To summarize, we can say that non-seminoma patients are treated in a risk-adapted fashion. Patients without lymphatic or vascular invasion should undergo surveillance and carry a relapse risk of about 12%. Patients with a lymphatic or vascular invasion should be given 1 cycle of BEP, resulting in a relapse risk of 3.5%. Retroperitoneal lymph node dissection is only indicated in selected cases and harbors a relapse risk of about 7%.